pulmonologist and scientific chair and chief editor of the Sri Lanka College of Journal of the Sri Lanka College of Pulmonologists. He is the head clinical respiratory medicine assembly in the Asia Pacific Respiratory Society. So he's a keen researcher, and he has given many orations and has a lot of publications in international journals as well. So I'm not going into much detail because I mean, it will take hours to describe about his academic career. So with that, I would like to invite Dr. Dushantha MADEGEDARA to deliver his lecture on long COVID, post-COVID syndrome and post-acute COVID-19 syndrome, I think, which is a very, very valuable topic for the current day situation. Over to you, Dr. Dushantha.
What is the video?
Okay, good morning. Thanks, Professor Artigala, for kind words of introduction. And then after a long time, I am giving a lecture here in KSIM, although I chaired several meetings here last 1.5 years as a president of Association of KSIM. And I'm enjoying the things, but we are today online, and all these lectures are uploaded to the YouTubes, which I introduced last year. Now I think the majority is in benefiting these lectures, not only the physically present here, as well as they can join online, and this will be I think uploading to the YouTube. That will be benefited by the majority, not only here, all over the world. Now the last 1.5 years, I think we are talking about COVID-19. Actually, KSM. But the last year, I think we held 2 symposia on COVID-19, various aspects treatment, and there are also a few lectures conducted on COVID-19. I think this year there was Vasanthi as well as Amila, the different aspects of COVID. Now we have experienced this COVID situation now little more than 1.5 years. Now we see the results of COVID-19 or the end effects of the COVID-19. As a clinician, now because now this is going on more than 1.5 years. Now this is time, I think even a year before, actually almost after 6 months of the starting of this problem in this country, we see the consequences and the effects of COVID-19. So now this is a high time us to talk about it. Now we all know about, you heard about enough presentation, enough lectures online and otherwise about COVID-19, clinical picture and various aspects of COVID-19 vaccine and so on. Now we need to talk about what is happening to these patients after COVID-19. We all know that unless you properly manage, come the late cases, you know what is going to happen invariably. They become really late, complicated cases, patients with several comorbidities or immunosuppression, or patients with elders in group extreme age, and some die or some succumb to the COVID-19. So that we all know. Even yesterday, I think 174 deaths. That being officially declared, as we know, that is not exact number. It's a number I think I got to know just roughly about 400 deaths yesterday. So that's what we see. But even if you escape from the death, but still you are not escaped from all other problems. They suffer a lot after the COVID-19 infection. So that as a clinician and the doctors who they are practicing in the hospital or private sector, wherever, we should have clear understanding of what is happening to these patients. So today's lecture is intended to give you some information, give some ideas about these aspects of COVID-19. That is not the acute infection, the infection sequelae or the after effects of COVID-19. So we topic like a long COVID, post-COVID syndrome, and the post-acute COVID-19 syndrome. I had a never-ending story. We realized a little later how is it true or not. I'm not going to talk about the very simple basic thing, the COVID-19, we all know now. But for me to get into this lecture, you need to understand about what is exactly the basic, simple pathophysiological basis of COVID-19. I just listed the effects of COVID-19. One is to direct viral toxicity. When a virus enter the human body and they can cause effects of the not only lung and multi-organ, heart, kidney, pancreas, brain, almost all the organs, cause a direct viral toxicity. Lungs is the mainstay, main place of that. Other endothelial damage is another very important aspect of COVID-19 infection. Another microvascular injury. Microvascular injury also another aspects, very important, the pathophysiological basis of COVID-19. Other one is immune system dysregulation. We have good immune system, all of us having, but this virus is change the regulation and going to have unpleasant, unaccepted consequences due to the hyperactive situation of the immune system. Another the stimulation of hyperinflammatory state, where the protective, all of what is happening as a pathophysiology is protective, but is causing more harm, like in allergy. Normal allergic reaction, it's a protective mechanism to the against a foreign substance, but it can cause a death within a second. In a second, can cause a severe vasodilatation, severe bronchospasm, and the acute cardiac arrest, so on. So this is a hyperinflammatory state. That's the biggest problem. The one biggest problem, what we call immune storm, antigen storm. Hypercoagulated state was the resultant in situ thrombosis and a macro as well as microthrombosis. Now, I lost a patient day before, young lady who came to me with 2 days of mild headache and mild fever, got admitted in the thyroid sector. She refused to come to the hospital, quite affluent. She had CRE for 28, ESR 32, liver, renal, everything is normal, visceral count was normal, about 8,000. Mild symptom, no temperature, chest X-ray, absolutely normal. I know how to interpret chest X-ray, it's not a big problem to me. I'm a respiratory physician. No, absolutely normal. Mild symptom, we just started some antibiotic, some symptomatic treatment. And the second day, she was a periorbital swelling, which, as I'm a clinician, so I see my patients regularly, so I know what to look for when they're coming, the unilateral swelling of the eye. So I check the next stiffness, I ask her photo, we are vomiting, headache, she refused, no headache, no vomiting, no further, no next stiffness. I written on the BST, the private sector BST, no vomiting, nothing. She was a little drowsy. She was otherwise she started, but I got immediately opinion from the physician with a neurological interest and has some training on my own training as well, and the eye surgeon and the neurosurgeon also get opinion because I thought this is aspect little beyond my area. Early morning 3 a.m. I got a call. The patient was drowsy. So immediately taken to the ICU of that particular hospital. She was otherwise normal breathing, but the blood gas acidosis 7.1, potassium was 2.1. Previously, everything was normal. I checked liver, renal, everything. She was drowsy, then we had, so we start immediately steroid, IV Dexa, suspected cerebral, change the antibiotic because of some of the infection, immediately call for necessary parties and or arrange urgent CT brain. And around 7 o'clock, we had to intubate her. And then the CT was planned around 6:30, but technician didn't turn up, so it was postponed. 8:30 was the result of PCR positive. And yes, I was there, so no history of collagen vascular disease, absolutely nothing. Then we did the CT with the force to do CT because they refused to do CT because of PCR positive. But I threatened them to do it. Threatened him. I filed a case against you and to the hospital board. And I asked the patient to do so, same thing. But you can't refuse. When the patient are in your custody and taking money, you have to do it. You like or not, you have to take your own protection. So anyway, we did it. There is severe skill thrombosis, frontal lobe is totally gone, infarction. We could manage only few hours up to about 7 p.m. evening. She died. No previous history, absolutely nothing. So these are the, so the hypercoagulability is, although unexpected can happen like this, and I got 2 quotes from the neurosurgery, I'm going to see just after this lecture, similar cases. So that remember, this is a hypercoagulable stage. The maladaptation of the ACE pathway, angiotensin converting enzymes. So these are the possible and known or suspected pathophysiological basis of COVID-19. This is important to know this particular basis because every effects are depend on this. So we manage having basic idea of this in my mind. So we manage COVID patient with this basic idea. And they are viral infection, they are prone to get a secondary bacterial, fungal, or any other infection. That also I forgot to mention here. Those that also I have to act as 8 groups. Okay. So basically, so that it could be viral dependent mechanism like in the viremia and viral toxicity, or viral independent mechanism like immunological damage, very important, including perivascular inflammation. A little more detail contribute to the breakdown of endothelial epithelial barrier with invasion of monocytes and the neutrophil and extravasation of protein, which is rich, high protein rich exudate into the alveoli, causing the alveolar space filling, like in the consolidation, like, or even the booth, bronchiolitis obliterative organizing pneumonia. All cases of diffuse alveolar damage, is it the viremia or viral toxicity, partly due to this or partly to immunological mechanism, and diffuse alveolar damage causing the organizing and focal fibroproliferative diffuse alveolar. It should be very quick, even maybe even a 3rd day or 4th day or even 5th day, 6th day can happen. If you have this basic idea, then you know how to manage it. Other is the rare areas of myofibroblast proliferation, mural thrombosis, and microcystic honeycombing. If they escape initial part, they go into the next step of fibrosis and may predispose to bacterial colonization and the subsequent infection, not only bacterial, fungal. That was very important to understand, bacterial as well as fungal and other colonization. And pulmonary vascular thrombosis and microthrombosis are very common, very important to know, but 20-30% of the patient, not only pulmonary, this can happen in vessels. As I mentioned, the case what I few minutes earlier. So any thrombosis can happen because it's an immunological mechanism. So the mechanism of thromboinflammation is very important to understand as a doctor. So one is the endothelial injury and complement activation, platelet activation and platelet leukocyte interaction, neutrophil extracellular trap, release of pro-inflammatory cytokine, disruption of normal coagulant pathway, that is disruption of the normal pathway, and hypoxia and signal to pathophysiological thrombotic microangiopathy syndrome. As a physician, we know this condition. So there are many factors or causes which lead into thromboembolisms. This graph is very important for you to understand that this is the COVID one. So you can see what is point. Anyway, so that you to the early stage. Nice, okay. Now the first the early stage, when we expose to SARS-CoV virus, early stage detection, that better after the 1 week, maybe a few more days. First, within that week, we may not be able to detect the virus. And then we get to detect the virus. We have the virus appearing in the nasopharyngeal route, or the respiratory routes. Then we know that we detect the PCR positive that time. Okay, this graph is there. So that we can, the other side here. So this is the early stage. So this is about maybe 1 or 2 weeks. This is area we may not detect. So then virus appear in the nasopharyngeal and the oral. This is a viral load. So a lot of virus in the nasopharyngeal route, and the respiratory one is little later getting there. So this time we may see that we will get the PCR positive or AT positive. Now you realize that about 4 weeks time, this is the area we call the acute disease for acute COVID-19. What we see in the managing the patient in the hospital, maybe pneumonia or AKI or acute myocarditis or aseptic meningitis or septicemia or whatever. This is acute COVID-19 within the 4 weeks of the COVID infection. After 4 weeks, after 4 weeks, when the acute part is over, we call a post-acute COVID-19. Post-acute COVID-19. That's after 4 weeks, after initial infection is over. But in this early part of that, up to the 12 weeks, you can see this particular one, we call subacute or ongoing COVID-19. All the viremia is less, viremia come down maybe a little, but process is continuing. We call subacute or ongoing COVID-19. After about 12 weeks. After 12 weeks, we call chronic or we call post-COVID-19. So after 4 weeks, we call the post-acute COVID-19, which has 2 components, subacute to ongoing, and this is a chronic or the post-COVID. So this particular area is the one I am going to talk about. This particular, both group, subacute to ongoing as well as chronic or post-COVID, this is what we call long COVID syndrome. So that is one, it is a multi-system involved. We are going to talk a little later. So the long COVID or post-acute COVID are the 2 components, the progressive part within the 12 weeks, and after 12 weeks goes up to 9 months, even more than that, is a chronic one or post-COVID one. So both categorized as one group called long COVID. It's a very important entity we need to go into. I am going to talk today in this particular lecture is mainly for that purpose. Now, what is a long COVID? Now, you understand what is a long COVID now by understanding the graph. It's a sign and symptoms that develop during or following an infection consistent with COVID-19, which continue for more than 12 weeks and are not explained by an alternative diagnosis. There can be other diagnoses can explain. So it is not a long COVID. It is purely due to COVID. It usually presents with the clusters of symptoms because it's a multi-organ disease. Clusters of symptoms often overlapping, you realize a little later, which can fluctuate and change over time and can affect any system of the human body. So it's very important to understand. It's a multi-organ disease. So breathlessness will come a little later. It's a multifactorial. That's very important. That's why we need a good clinical input into this. So the both ongoing symptomatic COVID-19 for 12 weeks and the post-COVID-19 symptom will include this so-called long COVID. It's a very interesting area. So why the long COVID is, now I explained you the pathophysiological basis at the beginning to start with this lecture. So potential mechanism contribute to the pathophysiological post-acute or post-COVID is due to virus-specific pathology mechanism. Whatever pathology happened is continuing, can cause all this problem. Immunological aberration and inflammatory damage in response to acute infection, or expect a sequel or post-critical illness. You'll understand. So there is a collection of all these together causing this post or long COVID or post-COVID. Why long COVID? Very important. Why long COVID symptoms? Collection of symptoms. That's very important to understand. Now, every side is interrelated. So post-viral fatigue. So one is that the post-viral after simple viral infection, just a flu, you all get a headache, body ache, lethargy after 5 days. Depending on your own personality, you may enjoy the 1 week of leave or you come to work on the next day. So that's a very important. Post-viral fatigue or lasting organ damage. It may be not only lungs, kidney, heart, pancreas, brain, or any other organ, liver, lasting organ damage can be, or multi-organ damage. So that this is together. Or post-intensive care treatment. I'll explain that. After patient intensive care, they develop a lot of problems. Post-traumatic stress disorder. Now, everyone who acquired the COVID infection has a fear of death. If I get it today, if I get severe pneumonia, I may get all possible treatment, still I can die. Sudden death, I die in the night. And only 4 beds available ICU in Kandy, National Hospital Kandy. 4 beds are almost always full. Not a single ICU bed available in the central Sri Lanka. Not a single ICU bed available in the private central Sri Lanka. Only 4 beds here, 10 in the Peripheral here. 10 is another 10. 8 beds available. If by having influence I may get, but I can't push the patient out, I will die in the middle of the night. I could not get ICU, not able to get ventilation. So don't you get a fear of death? Everyone will get a fear of, because no one knows what is going to happen. And now I am good, but now another 6 hours time I may not able to breathe. 6 hours after I had to ventilate. That is COVID. So fear of death is natural. Everyone who acquire the infection. So post-traumatic stress disorder, nothing to worry about, think about. This is that. And the worsening of the existing medical, if I have asthma, COPD, or ILD, or heart-prone, diabetic, every medical problem can get worse. So it's a collection. Long COVID is due to collection. Now, the multi-organ effect COVID-19 is very important. So multi-organ disease is a broad spectrum of manifestations. An increasing report of the persistent and prolonged effect of after is very common now. After COVID infection, we have increasing symptoms after you recover from the acute. Multi-organ effects can also include the condition that occur after COVID called multi-system inflammatory disorder. This is a new syndrome. It's a new condition. Like in we have discussed this inflammatory syndrome in COPD, HIV, like that, similar thing. It part is the autoimmune part. Like it is unknown how long multi-organ system effect might last and whether the effect could lead to chronic death, chronic health condition. May go even after 1 year. After 1 year. Even people who are not hospitalized, remember that very important, have a mild disease or even just a COVID infection, not the disease, will develop the long COVID. You don't have pneumonia. You just acquire infection only, but no disease, nothing. No disease, but you acquire your infection. You rat positive, nothing here. But you develop the long COVID. That's very important to understand. But I get enough patients in the private sector and affect any age or the both sexes. Who get the long COVID? Who are the people who are more prone? We have experienced as increasing age naturally, because they are in every organ of the human body are old. So naturally, when you have another insult on top of your old, say about 70 person, say heart is 70 years old, lung is 70 years old. On top of that, you get another insult. Naturally, we have more problem. In excess weight, obesity is naturally associated with a lot of problems. We lost few patients. Even now, we are managing very difficult obese patients. We have a lot of other respiratory problems, obesity, hyperventilation, or sleep apnea, or diabetic, everything is common. And the female gender, I don't know, some reason or other, common, asthma, very common, and multiple symptoms at the presentation. These are the group where they are going to have a long-term effect. Not on long-term, they are going to have very bad outcome also. And patient may not have positive COVID test sometime. That also COVID, because if you have just mild headache, no one going to check the COVID, but I see the patient after 1 month coming and see me with breathlessness. When I do the FRCP, lung is gone. But PCR negative, because this time is gone. Now that is not time to PCR positive. All are post-COVID. May not be 100%, but maybe influenza itself, but that's mostly in this time. And the children also, 12 to 16 to 15%, even a small children also, about 13% can have a long-term effects. What is known about this, a UK Office for National Statistics, they say that 1 in 10 respondents may exhibit a symptom for a period of 12 weeks or more. So very common, 1 in 10. It's not that, and 1/3 not return to normal previous health after 12 weeks. That's very important. After 3 months, about almost 3 months, they are not back to their normal health. And that's very common. I'll tell you later. 30% had a symptom after 9 months. So that's the never-ending story. That's the trademark of the. It's a multi-organ involvement. Each and every organ of the human body. Now you see about fatigue, respiratory, musculoskeletal, neurological, like general, almost all organ will involve. So the long COVID, so some symptoms like I say was fatigue, shortness of breath, joint pain. This actually reduce some of the mobility, so that will cause a disuse, and that is very important. Disuse atrophy and lot of things, and some of other features like say about loss of smell, loss of taste, and lack of appetite, diarrhea. That is not uncommon thing. They can cause a very poor nutrition states. So sometimes the further lead into the other problem. Expected recovery after COVID infection. 4 weeks time is a reduction in the muscle aches and chest pain and spirit. So 1 month we expect them to have some improvement of the 6 weeks. Cough and breathlessness substantially reduced in normal sequence. Not the people who are leading for a. So 3 months, most symptoms resolve, fatigue may persist. 3 months time, sometimes unrolled system. Post-COVID is starting the long COVID, the real post-COVID is starting. 6 months, we expect this complete resolution, but some symptoms may persist. After that, I talk about the different areas. Post-COVID breathlessness. This is one of the commonest manifestations we encounter in our practice now. Post-COVID breathlessness. This I thought, these are not in the books, what I thought in my experience as well over 20 years as a respiratory physician. One possibility of breathlessness, this is what I teach my trainees as well. Someone coming with a breathlessness may not be found in the books, but this is what I think. One is what I call reactive airway dysfunction syndrome. Any viral infection can cause a disease. They are mimicking asthma, but this is not asthma. They have bronchospasm and breathlessness. We call reactive airway dysfunction syndrome. Second is very common in this post-COVID patient are secondary interstitial lung disease. Very common, unexpected, surprised to see that so many cases of interstitial lung disease, even at early phase of the disease, even 9 day, 8 day, but we are managing very early because of that patient escape. But even with the maximum management, with all possible treatment, so it will be bronchiolitis obliterans organ pneumonia, AIP, acute interstitial pneumonia, NSIP, non-specific pneumonia, mixed pattern. That's very common. That's it. Other one is a pulmonary hypertension and pulmonary embolism are uncommon. Cardiac causes, breathlessness, myocarditis, ventricular failure, congestive cardiac failure, viral induced cardiomyopathy, worsening of the coronary, all are lot of cardiac causes. Maybe even a rhythm abnormalities, all can cause. Other one is called bronchiolitis obliterans. A small airway can cause a bronchiolitis obliterans. They are not interested. It's a different group of disorder. The drug-induced disease. Now we use a very high doses of steroid and immunosuppression. They can cause a myopathy and muscle wasting, so many fractures and fibrosis. So that also we need to know about when with very high doses of steroids. Not the day of first day if they are hypoxic. Critical illness, myopathy, and post-intensive care, so we come a little later. Not only critical illness, myopathy, critical illness, neuropathy, also very important. And exacerbation of existing illness, like interstitial lung disease or COPD, asthma, including or maybe heart failure, they will exacerbate, even for diabetic. So that was a part responsible for breathlessness. Other post-traumatic stress disorder, they have no more than me. I know little about this. So it's a breathlessness come as that part of that. Deconditioning. When you are in the ICU for 20 days, not moving, when you cannot turn even, because of severe hypoxia, do you expect your muscles to be straight? Psychologically and physically and mentally, you're going to deconditioning. It may be you are eating, overeating. We have a few patients in my S2, they are eating like nothing. They are the raised BMI, the opposite was same, the low BMI or malnutrition. All I remember, so we have to survive and we have all muscle, everything, you need a trace element, vitamin, everything. If you're not getting your magnesium or zinc or essential vitamin, you lose your muscle strength naturally. And not only stress and high cortisol dose and steroid, that's very much. Opportunistic infection are very, very important. Fungal and any of it, including TB and the functional. Because post-traumatic was a part of transfer, but there are multiple factors, but other functional one may not have anything. And these are the intensive care associated weakness, come a little later. And other organ failure, maybe CRF or pancreas or liver or heart, whatever. So there are many possibilities which I thought are the possible causes of breathlessness with the patient who are coming after COVID. These are not in the books, but this is what I thought and added the list. Now the respiratory features are very important. The fever, cough, fatigue, these are very common in the acute one. So when they are more common, there will be some patient continuing that. The long-term respiratory symptoms are again very common, like in the CNS in normal, they can have 21 symptomatic at 5 weeks. I'm not going to read this thing. So the long-term effects of cough, breathlessness, chest pain. Remember, chest pain is very important symptom. I get a lot of patient post-COVID chest pain. Just go to the myalgia or partly it may be a costochondritis, muscle or reflux, many reasons. Not only myocarditis and other things, pleuritis. Post-COVID breathless so may vary from person to person. That's very important to know. May not depend on the age or sex or other common. Sometimes nothing, absolutely healthy people had the COVID pneumonia coming back with this one. Very common. It's not uncommon. Need total assessment. That's very important. From head to toe, total history. I told you up to 14 causes of breathless. Have to look for why. Do you treat the exact cause? So you can't treat like ILD having a bronchiolitis obliterans. It's two different conditions. For post-traumatic one, I have to get my colleagues' support. Not that I'm going to treat that. I can't. That's not. If I deconditioning, it's a different thing. Then I get my rheumatologist and physiotherapist, and that all have to ignore. And the history and examination and investigations are essential to come with the sum. So we do the basic organ assessment, ECG and echo and etc. And we do detailed lung function, including MEV, maximum voluntary ventilation, see the muscle function, diaphragm and intercostal, and chest X-ray, HRCT and CTP. We do that very commonly. The diagnose interstitial lung disease and the pulmonary embolism and etc. And 6-minute walk test is very important, and the DSU and Medical Research Council Dyspnea scales are very important to assess the pulmonary status. And the bronchoscopy, if you suspect secondary infection, we may do like a fungal, we have to get a bar. Sometimes we cannot come to diagnosis. If aspergillosis, we need a bar. So these are some of my patients, chest X-ray or post-COVID. See that mild ground glass, this is very fibrotic change. These are the fibrosis more than that. Third one is a really bad fibrosis. These are all our patients. This type of states are bad patients, will be really dyspneic. These are the HRCTs, generalized ground glass with some organization, fibrosis, peripheral fibrosis. They are peculiar types. These are peripheral linear fibrosis. So these people can't walk 5 feet. Remember, they are really dyspneic. The saturation will drop right to 70% after that when you start to walk. So these are again our patients, ground glass, fibrosis, but cyst, pleural effusion, cavity. These are not features of post-COVID pulmonary changes, but you can have second infection on top of the ILD. So then you may see. These are all our patients. Every bad lung, like these all our patients, very bad lung. Any type you see, any type of intestinal you see. I can give oration on that. We have so many collection. So management, you have to come to diagnosis. What the patient is having. Then a multidisciplinary approach. We need our psychologist, psychiatrician, cardiologist, or whoever relevant, we need to get the opinion. And the general managements are essential, starting with the talk and symptomatic management. And the specific management depends on the interstitial lung disease, where you high dose of steroid and all the immune suppressors. You give perpenidione, we have 99, but like that, there's a lot of drugs. I'm not going to. And the pulmonary rehabilitation, essential component. It's a syndromic approach where you can everyone to ignore. Psychiatrician, counselors, physiotherapists, nutritionists, cardiologists, and ourselves, all. So it's very important. These are just things from the positioning, breathing control, and various things desperate. There's some other presentation. Now that's the lung one. So the lung one is a lot of problems now. From the myopathy to the interstitial lung disease, airway disease to anything you mentioned, COVID can cause. The question time I will answer. Cardiovascular disease is another important group of the post-COVID. They present like a palpitation and tachycardia, sometimes due to the arrhythmias, unexplained due to the maybe SA node, AV node problem, maybe still, but dyspnea. Chest pain is very common. There is difference. It is just a muscular or psychological or the cardiac cause. The arrhythmias are not uncommon. Autonomic dysfunction, hypotension, those are very important. And the long-term sequelae due to increased cardiometabolic demand or myocardial fibrosis and scarring. These are not uncommon. I have seen enough cases of influenza pneumonia, influenza infection. Same thing can happen. COVID will be worse than that. So the very important where our cardiology colleagues are involved in the management, not ourselves. Neuropsychiatric are not uncommon. Fatigue, myalgia, headache. I'm talking fatigue a little later. Headache, dysautonomia, and cognitive impairment. Very common. They come with, I told you the many reasons why they can anxiety, depression. Naturally, you went through the phase, you just narrow escape. Lethal patient, you're fine today, you're fine, your lethal family members also down there, he's okay, improving. Same day night, he's dying. So what's the situation? So naturally, then he got the patient in the middle of the ward. ICU, both sides the patient are dying when he is observing that. One patient came and told about 26 sometime before. About 9 patients continued to die when he was in the middle of the bed. Young man came and told me in the private sector. That time there was not a proper management anyway. The people didn't have to give even oxygen. Pound dead. That's a very bad situation. Now much better than previously. Pound dead. Who can't have pound dead in the hospital? So I am in the middle of the ward. Both sides my patient, the patient in the beds are dying like nothing. So you will be the next one. So what are the mental states you're going to young man having a family and a 1-year-old kids and 2-year-old child? What is going to happen? You are the only breadwinner of the family. You think everything is possible under the sky. Can you escape that clear psychosis? No, never. Again, we'll have a loaded crowd. because it's not possible. That is exact situation. Doctor not coming to the patient, nurse never coming to the patient, attendants and others are not coming, ECG fellow not coming, chest X-ray refusing, physiotherapy is refusing, no one going to give oxygen, no nebulizer. That is the exact situation was. Now much better, even with the post. Even with the post, we are doing that. The post. I'm getting the why I got my SQL thing. Others know that I'm going in. That is excessive. So whatever you say, doctor, your doctor never come to you, never examine you, not even talk to you. What is your situation? Here psychosis, everyone will get it. So I'll show you a little later another slide. So endocrine, they have a newer version of the control of existing diabetes. Very big problem because they can get a pancreatitis, pancreatic vascular obstruction. Anything can happen. So diabetic control is the biggest problem we have in our management. I think Nandan will agree with you. And subacute thyroiditis, bone demineralization, these issues as well as malnutrition, many reasons, high dose steroid, high dose of cortisol, hypothalamic pituitary axis natural. When you have that type of disease, you get your whole pituitary axis suppressed. Hyperthyroidism, I actually can't think of why it happened. Maybe some dysregulation. These are the things can have endocrine. So the non-COVID-19 fatigue is another biggest problem in this group of patients. So fatigue is reported to be one of the most consistent and the persistent symptom people experience following COVID infection. And they have a lot of problems. Physical, due to many multiple factors, physical causes, sensory, functional, psychological, and cognitive impairment, as well as social and personal relations. So you are a normal man when got the COVID, went to the system, coming out, you can't go to the washroom. You cannot. So this is the multiple reasons. So there are increasing age naturally because your whole system is old. Slight increased risk of female, I told earlier also. More this multi-system, your heart gone, kidney gone, lung gone, the dysregulation, metabolism, so all kind of BMI. Obese, so opposite. Looking at the age of individual and the number of symptoms experienced in the first week can be a reliable predictor. I told at the beginning also. Elderly, multiple symptoms are the people who are going to acquire or experience a character. So this is the causes of fatigue, many I told you. Muscular causes, disturbance sleep, diet, and also anxiety, immune system problem, coexisting health problem. So there are multiple. The problem is that fatigue will lead into what is called chronic fatigue, and then we lead to chronic fatigue syndrome. I'm not expert to talk on that, but I just give you slide. And Diane has known about this better than me. And Shama all know better than me. So just like the fatigue and chronic fatigue and chronic fatigue syndrome is a so the chronic fatigue is a very common, as I told, physical causes. I'm not going to detail, please this idea. Cognitive and psychological and emotional factors. This lecture will be there and everyone can take it. And this will be uploaded in, happy to upload into the KSM YouTube, everyone to see. So the chronic fatigue syndrome is a different condition, as they mentioned. I'm not expert on that anyway. Once alternative fatigue causing implications have been considered and eliminated, consider diagnosis of chronic fatigue syndrome. So they have a lot of problems like post-exertion and malaise. They walk and sit. Fatigue with a substantial reduced normal activity level, muscle weaknesses, feeling dizzy. Very common. I am getting patient. I'll tell you at the end of this lecture. At least about 25% of my private practice these are something related to the COVID. Yeah, 25%, a little more than that. 40% of my, I think, yeah, at least 30% are related to COVID. All COVID patients who comes and see me in private sector, maybe other respiratory centers the same, are related to something related to COVID. So the needing a rest to or sleep more, altered mood, and cognitive disturbances. These are features of chronic fatigue syndrome. So management, we have to get definitely our psychiatrician's opinion, and they are the expert on that. They reassure the routine gentle and rest and sleep, hydration. So whatever factors we need to correct it, and the associated comorbidities needs to be looked for and treated. Like reconditioning is the biggest problem. So we give a lot of supplement, graded exercises, and all important. I think the Australian people will have a lot of work, musculoskeletal problem, a lot of work. So we have to take them back to their normal life. So fatigue, I'm not going to take this is the same thing. Repeating fatigue, breathlessness, physical activity needs to be addressed in chronic fatigue syndrome. Other thing, actually, psychological care recovery from the COVID-19 is actually it's a very common thing. So the factors of what are the factors? Psychological disturbances. For people severely affected by COVID-19 require hospital care. The other, and pride in the invasive nature of critical care experience. I told you, I gave you the example. Both side patients are dying. Not only, and patient come next, he also got dying. That's what happened on Monday. I think the COVID ICU and the HCU almost all died. So who escaped? So what do you think about that? And the isolation of the loved one, naturally. No one. Some people are keeping and no one coming. One of the doctor, retired doctor was there. We could not find a single person to come and see him or to bring something which we want for a management. Not a single person. But not some community, some are very good. Not all. Some patients. Because maybe that's physical, maybe the quarantine also. That you understand the practicality. But no one coming. You are alone. Doctor was not coming. The health claim was the same. But not now, earlier. But this situation. That's why patient died at home. Do you like to die at home or do you like to die at here? I like to die at home because my family is around. They give me water, they be on my TV. At least they bring my phone. I can see my normal work. I don't mind if I want tea, they will call me here. No one. Do you like to die at home? I preferably die at home without coming here and dying here. And my body also didn't no one see one body and burn somewhere, not even family people to see one body. At least people can see, the family people. So better to die at home, coming and dying here. That's why people died. Lot of die even still today at home. You understand actually, I told the Director General of Health, this is the reason. Change the people attitudes. I told him myself directly. This is the reason. This country having such a pre-health system, such a good health system, why people are dying at home? It's very important. So stigma, so these are very important. So these are the factors, psychosocial. This is very important slide. Community post-COVID, people who are affected by COVID, what they have, this is a good study, I could not quote it. Depression very common, 20 to 40%, anxiety, and you see the level, post-traumatic stress disorder 2 to 5, fear of COVID, 20% and memory and concern. So these are the people who have COVID in the community having the problem, including sleep. 4 to 60% cannot sleep. They cannot adjust to life. So this is a community. Hospital discharge patient. Now see the depression 40, memory impairment 50. So what is the percentage? I told you. These are people who are discharged from the hospital. People who are in ICUs, see the rates. So almost everything is more. So people who are discharged from ICU, HDU, unless you go to the patient, talk, have friendly chat, look after them, then this can be changed. But not otherwise. This is a healthcare frontline staff, doctors, nurses. They have depression more than anyone. We also get depression when the patient go. I told you can go home today, few days time, and midnight he's dying. So I also get depressed. So that more than that, people are maybe depressed. People have anxiety and psychosis for nothing. They are not doing their normal duty. This is see how hospitals care. They are more than the patient. Maybe partly depression due to what's happening in the patient. But see I think you can start another clinic for this hospital staff. Otherwise, the post-traumatic stress disorder, I think it is defined as an individual who have been exposed to the traumatic event in which one person experienced a witness or was confronted with actual or threatened death or serious injury or the threat to the physical integrity. So I got from some presentation, I don't know what. But now you understand, I was explaining up to now, that is exact situation. Post-intensive care syndrome is another one. When you're in intensive care, they are very important. Is the ICU acquired weakness. We call ICU acquired weakness. Cognitive dysfunction, psychological and other factors which I am explaining up to now are very common. What are called post-intensive care syndrome. These are called ICU acquired weakness is very common due to critical illness myopathy and critical illness neuropathy, and at least 10%. That's a loss of muscle mass if you stay 1 week of ICU. Remember this. So there are a lot of other factors, stress and fatigue and multi-organ involvement, malnutrition, all that. It's called ICU acquired weakness. This is another condition, interesting condition called mast cell activation syndrome, where the relatively unrecognized entity, so despite its great prevalence, we are not diagnosing this, which are like to be camouflaged by its extreme heterogeneity of clinical. These symptoms are common symptoms shared by the almost all the conditions associated with COVID. They have respiratory symptom, multi-organ disease, very common. 17% of the population will have what you call mast cell activation syndrome. They may cause severe acute COVID-19 and chronic disease. So that is a very important disease, and this is no one knows exactly a lot of detail. Something to do with the histamine receptor antagonist or low histamine diet, something. So now you go through, they have almost all the organ involvement. They share all common symptoms. So I'm not going to detail. Mast cell activation. Other one called multi-system inflammatory syndrome in children. Not only children. This can happen as a multi-system inflammatory syndrome in adults and multi-system syndrome in children. Sometimes I think you may have heard about 1 month, 2 months people in the TV or talking about this. It's defined by the presence of the following symptoms. In people less than 20 years old or less than 19 years by the WHO. These are fever, elevated inflammatory markers, multiple organ dysfunction, current or recent SARS-CoV virus infection, or exclusion of other possible diagnosis. I'm not going to do the whole detail. It's another condition, something to do with a multi-system inflammatory syndrome. I told you at the beginning this one. So this is very important. Other thing is a management of primary care. That's very important. Remember, Sri Lanka has a very good health system, very good primary care system, the vaccination and the other management. Unfortunately, this system is not yet mobilized for the benefit of this patient. So there are also, all these patients are in the community. All the doctors who practice primary care, the private or the government sector, go through this patient properly, take a good history, examination, do the appropriate investigation, need to refer to the specialist on the relevant field. I'm not going to tell you the detail, you all are doctors. So I have to go through and find out all what I explained up to now, which organ is ignored, what is the status. If they can manage, they can manage. Like a simple fatigue, they can manage. If the ILD, they can't manage, they have to refer to us. So myocarditis is referred to cardiologist, for example. Post-traumatic one, they go to our psychiatricians. So the primary care is very important, very, very important. Unfortunately, this is not happening in Sri Lanka. In other parts of the world, this is very good. The holistic approach is I'm not going to. So some patients we can advise you of self-care. They can do their own manner. Other one is in other countries, they have a guided self-care. They know the patient, they will be over the phone, they will be discuss with the patient, manage accordingly. So if they cannot, they have to refer to the specialist, and complex cases has to be managed in the hospital. So I'm not going to a lot of work, but this is how the long COVID assessment is happening in other parts of the world, not here. So you get a good primary care team and the post-COVID team where the doctor, nurses, and physiotherapists and all can ignore. They go through the patient, initial telephone assessment. If they think that they can manage on their own, advice, bring them to the clinics, wherever it is there, and then refer. This is a system happening in other parts of the world. I'm not going to do so. That is very important. I think we will have a bigger percentage of our citizens will have this post-COVID complication. So that is why we have Department of Health and the Ministry of Health. They are doing nothing. They are doing nothing on this because they never take expert opinion. They never take it because they are not expert, or they call specialists. They may be something else, but not this. So get the specialist opinion and then get the whole teamwork and get the primary care physician, family physician, all we know have a good system, but unfortunately, never they are thinking, never talking about this. And the COVID clinic, so that's it. I am very happy to say that I am the first person in Sri Lanka start a post-COVID clinic in this country. In the Bogamba Chest Clinic, Friday 1 p.m. with official approval. We are roughly about now 1 year or 7-8 months, I think. It's a thundering crowd from the 12:30 to my doctors go sometime up to 4:30. Even we diagnosed second COVID in that clinic, remember, so that particular lady. Second COVID, unfortunately, that lady after proper management, she died in the referral unit with some renal problem. Second COVID pneumonia also we diagnosed in the post-COVID, and we diagnosed a lot of interstitial lung disease and thrombosis and so many problems. So it's very important. It's again multidisciplinary team where the respiratory, cardiologist, hematologist, everyone should ignore and go to the patient and find out and diagnose appropriate management. It's very important. Now most of the places started by our respiratory physician, but I started in this country first. Myself and my junior, they're doing that. We both of us ignored, and it's a very heavily crowded clinic. So there are again the total clinical assessment, history, general, all investigation, all relevant investigation, and the proper management come to definitive diagnosis, treat accordingly. So this is again the Everything we have to do it, because this patient needs a proper care. So the rehabilitation is very important. As I told you at the beginning, I'm not going to detail, same thing. So get the patient, find out what they're wrong with them, and do the appropriate investigation. Sometimes you need symptomatic management, sometimes you need specific management. This summary as such. So I'm just going to start. So typical rehabilitation start from the acute stage. That's very important. The acute medical status. When the patients are here itself, when the patient ICU, the good physiotherapy and supplement and psychological should be start. The subacute later, and then we should manage the throughout until patient back to normal. So we can. So that's why we need a physiotherapist to go in. So in my STO, they are coming daily now. They are doing it daily. I told each and every COVID patient should be, unless we said no, first has to do the physiotherapy, legs and limbs and intercostal and diaphragmatics and etc. etc. So start from the acute, go on and manage. So these are the first waves, and this is a different slide taken. So the first wave, immediate mortality and morbidity, you see this. Second wave, you see the impact of resource restriction and a lot of problem what you see. Now that wave is a different problem, the different way of modify. What I going to tell that, so the post-acute care is a fifth wave, and after all, we have to manage things properly. So there are a lot of research going on. That's it, recovery, and I'm just telling the postgraduates, if a registrars are around, they may definitely why your question will be on this. They should know what is happening in the Qatar. So a lot of research going on longitudinal, and this is a lot of research. In other part of the world, they have prepared this type of slide for information of the patient. This type of slide again long COVID for educational purpose. So all the medical communities are seeing this type of slide. Summarized notes, nice summarized on long COVID in primary care, and so these things our ministry should do, but nothing happening. So that's what I want to tell you. If for any question, I think I have taken roughly 50 minutes or 45 minutes. I think there are 5 minutes for introduction and others also. So remember, so this is never ending. That's what I want to tell you. You have to manage patient acute disease properly, and thereafter, this patient has to be followed up by your doctors, medical and relevant specialties, and they have to be managed. Try to take them back to their normal life after this acute COVID. So that is very important. You may die at this. If you escape, you are suffering your whole life. Unless you manage the proper interstitial anesthesia, you cannot do anything. You may not be able to go to washroom even walk. So that's very important. So you have to manage the acute properly, as well as you have to manage the patient until they are back to the normal or the reasonable normal life for activities of daily living. So in question, I can answer. Hope I gave you some idea about what is mean in the long COVID and various type of sequelae related to the post-COVID. After a long time, I came here for a lecture. Every doctor should know. Yeah, yes, Asena. Thing is this now, if they are properly vaccinated, both vaccine, when they develop the proper immunity, they cannot, according to the, but remember the 85% protection, some are 90%, the 10 can have it. If they get a proper infection, they will get it. Even after both vaccine, they can do 85%, 95% the protection. That's all. They also, we had a few cases, we had several cases now, out of both vaccine, they get a full COVID. When they get a full COVID, same sequelae can go. But if they're properly vaccinated, sometimes they will be stopped at the level of COVID infection, because they will not get a pneumonia or nothing, but they acquire, but they spread the disease to others. They are the carriers, but they may not get a disease. But depending on their immunological response, how their immunological response, they may, because that's not, I think, as far as I remember, may not, but they can develop, may not into the severe parameter, but they can do like a boo. So even when you give the influenza vaccine, they also can have influenza. But there's no guarantee that we are not getting. That depends on how your immune reaction react. With my normal experience, I'm answering the question. But one vaccine, we had enough patients who come with the full-blown COVID. One vaccine is absolutely enough. Just two. After two vaccines, at least I think Rohit was not around. At least you need 1 month. 1 month. Actually, unfortunately, we are so busy these days. We don't have time to even read and get updated close at the new thing also. Today night I'm planning to do that. Because this was prepared lecture, that's easy for me, otherwise I could not have time to even prepare lecture even. Okay. I did a similar lecture in Colombo, so I thought better Kandy also know this thing. Okay. So that's my answer. Have I answered your question? But remember this immunological response, viral diseases, their behavior, no one knows. No one knows. No, that's the thing. That depends on your luck and your God or whoever about you. This thing. Some people elderly having interstitial and having every complication, nicely going, nothing happening. Because I think the immune system was knocked out by early stage. Good. In a way, it is good. Healthy young fellow, that's what I always tell my people. They get a hyperactive immune system. Because you are young, you are strong. Hyperactive, you're not good for anything. No? Immune system was the same. So you destroy your whole body because of your hyperactivity. At the immune system, you're down, at least that damage is less. Virus try to go on their own, but virus may not go up to some. The virus may be good fellow, no, he may have a sympathy on the particular guy and he finishes it up his job. But if the immune system is hyperactive, I always say the TB, the primary TB versus post-primary. I teach my students that post-primary TB, more destruction. Why your immune system is very good. So we have a lot of destruction, cavity, fibrosis damage. Primary TB, no issue, because you have no specific immunity. Virus or bacteria on their own will do if we are good. If we start in, they will escape. Or your own normal immunity. But you are hyperactive, that's what is happening here now. Finish. There's a dilatation, every organ damage, AKI, MI, arrhythmia, all are due to the hyperactivity. That's my way of thinking with our experience also. That's what I think. So your immune systems are down, I think much better. Sometimes virus behave even not that every alpha or beta or theta or delta or not that every virus is same, no. There's a different virulence, different things. Any questions? I hope you have some idea what is happening. Every doctor should know, I think. Sorry.
Thank you very much, sir, for that wonderful lecture. As you know, the managing COVID, you explained about all the dimensions of COVID. So it's not just giving injections, not giving ceftriaxone and not giving dexamethasone. There's more than that. And you're like living a library for us and you're in terms of respiratory medicine. And thank you very much. And another notice, we have a neurology certificate course of neurology workshop on next Tuesday. And you can register it now because there's a limited number of participants we are accepting. It's online as well as the physical. So you can, either way, you can participate with the lecturers from the Colombo as well as in Kandy. So thank you very much, sir. And as a token of appreciation, I would like to invite Dr. Gihan Nabewardena to hand over the certificate to Dr. DUSHANTHA. Thank you very much. This is all the participants physically as well as the online participants.